And now we're inviting Joyce, who is his mentor, who will now see if he can do just as good a job on the immediate hemodynamic and echocardiographic effects after Impella 5.5 implant in over 100 patients. Joyce, take it away.
Great. So my presentation is really short, so I just wanted to say the biggest pushback to getting our patients on the step down was nursing.
Yeah.
And so we have we presented this at the breakout, but we have really strict guidelines. They can only come out during the daylight hours. There's a very steep handoff, warm handoff, we call it, from provider to provider. It's an APP-run service. So the ramp up of teaching was really intense for those APPs. And I was telling Jason that I spent the first night there was one on the floor, I spent the night in the hospital with them. Nothing happened. They're like the healthiest patients. So they're running the hallways. So thanks for I don't know why I brought my phone up with me. Here, Mark, you want it. So immediate hemodynamic and echocardiographic, yeah, there you go. Effects, don't text anyone. And so these are my disclosures. We all know about the microaxial flow pump by this time. And so the data that we're going to present are the patients in whom we have pre-implant hemodynamics and immediate post-implant hemodynamics and echo images. And that was about 103 patients. So to look at what they look like, these were 103 patients with an average age of 55 years. The most common etiology was an ischemic cardiomyopathy, and the majority of patients were SCI-D. And you can see here what the immediate effects were. I know this is really small, I don't wear my glasses, but the PA pressures, systolic and diastolic, came down significantly. The MR, the degree of MR improved significantly post-implant, but as you can see, the right atrial pressures did not change significantly. So the Impella 5.5, as we said, the MR gets better, the PA pressures get better, and with that, the RV tolerates it. It's interesting, the LV internal end diastolic diameter did not change. And the RVs, so we presented this previously, that really there's a low chance that patients require biventricular support when the primary lesion is left heart failure. You can usually get away with univentricular support because you're unloading the right-sided pressures. So we also showed that the patients in whom need escalation to biventricular support, we showed that their CVPs were rising over time, their PAPI scores decreased, their VIS scores went up, and their creatinine worsened. So we're working with the cardiogenic shock working group to compile a larger cohort of patients and to come up with a risk score as to when to consider upgrade to biventricular support. In our center, that'll be Impella, but in some centers, that'll be Impella. With that, I'll thank you.
Thank you, Joyce. And yes, that was short and sweet. That was great. This is open now to discussion from the panel. We'll start off with our panel.
So, Joyce, very, very nice, but are you surprised that the hemodynamics only improved such a small amount? Because I would have thought that the PAD, wedge, all of those would, with a 5.5, remarkably much, much bigger improvements.
Right. I think this was really early on. This was like 24, 48 hours. So I think there's, in those that we use general anesthesia, so a lot of our patients, as Jacob presented, we're doing just regional blocks. And so they get anesthesia, they get volume. I think as we move away from that, we're going to see much bigger improvements in the hemodynamics post-Impella 5.5.
Yeah, because the improvement of PA pressures takes time.
Yeah.
And we know that, but I have a question for you.
Can you put my slides back up, please? Sorry, go ahead.
So you report improvement of mitral regurgitation. You reported improvement of mitral regurgitation. So, but usually you can have a non-adequate improvement or the improvement that you expected in the mitral regurgitation. If you have a patient that is recovering and is go to recovering and you are in trouble winning off the Impella 5.5, what is the approach of your team in order to deal with the residual severe mitral regurgitation on 5.5 Impella? If the position is adequate and the Impella is
So
functioning.
it's not interfering with the mitral apparatus.
Absolutely.
Yeah,
If the position is fine and the Impella is working, the pump is fine.
Yeah.
So, but it's still you have severe
So
MR.
it's still treating those hemodynamics. So aggressive diuresis, inotropic therapy, vasodilatation, afterload reduction. So we're still medically treating these patients.
Do you consider or do you have any case of clipping the
No.
mitral valve?
No, I haven't, no.
I don't know you're allowed any additional slides, Joyce.
I know. But I wanted to show you the ones who progressed to biventricular support. You can
Go
see
for it.
there. You can see it there.
Yeah.
So there were the patients who their RA pressures. This was the baseline data, so it's really interesting that the baseline right atrial pressures were the same in those who did not require upgrade versus those who did require upgrade. But what did change was in the blue. It was the right atrial pressures over time, the VIS over time, and the PAPI over time. Yes.
Yes, here in the University of Texas, we have different results. We have patients that has severe significant mitral regurgitation while on Impella 5.5 support, and they did not improve the degree of MR. And actually, we're looking into, because some of those patients, because the elevated pulmonary pressures that we didn't know how much was the component of MR versus the pulmonary vasculature issues, they went for durable LVAD. And as soon as we put the centrifugal pump, on the apex, there was a significant improvement of the MR. So this is a confounding factor for us sometimes, and we're trying to understand a little bit more. But, we review some of the hemodynamics changes, and there is a good unloading. The problem is some of these patients, there is forward flow for the Impella, but it's a backward flow toward the left atrium because the low atrial pressures. So our results are different than yours in this regarding.
Yeah, it certainly doesn't unload as much as the HeartMate 3. We definitely found that to be true, but it does do some unloading. But I think we also have to make sure that we're still aggressively treating them medically.
I think this is a gross generalization, and I agree with some of your findings. In general, though, it's similar to VADS, though. It's those patients where the LVDD is about 7 centimeters, so it's greater than 6.5. But so the LVDD is 7 centimeters. There's tremendous tethering, and the mitral annulus is 45 millimeters or greater. The idea is, so those patients will get a little bit, but the idea is the LVDD is not going to reduce in size, so the MR is not going to go away. So, because my question for you is going to be in the panel too is, so how often do you get an echo? Because for us, quite frankly, is we actually just base it off of our sort of SWAN parameters. I mean, if the numbers get better, fine, and then ultimately just take the SWAN out.
Yeah.
Because whether it got better or not, it's not going to change our path.
Right.
So the issue is, when do you get your echoes and how often?
So we get our echoes, so we do a focused echo once a week for placement. So it's just a quick, put it on, make sure the Impella is still in okay position, and that's it. So that's once a week, because our patients in our region are waiting 3 months, 4 months for transplant.
For us, we do echoes as needed, depending, especially as they stay on longer for 2 to 3 months. But we also, for us to monitor how is the right ventricle is doing and how is the PA, most of the time these patients require their SWAN for about 5 days if they truly have very bad right ventricular dysfunction. And then after that, we see that clinically how they are responding when getting out from bed, when coughing, or when challenging with any diuretics, with renal function. We have seen multiple of these patients really showing us clinical signs before even their pulmonary pressure improve or their right ventricular parameters improve on echocardiogram.
Jason?
Yeah, same. We'll get usually a formal echo after placement, and then as needed, relying on a number of different factors, including invasive hemodynamics or for troubleshooting, to be sure. And a lot depends on intent for placement.
Yep, we order echoes like drunk sailors, but my sense that it's probably the same, but maybe a little bit more frequent and with any sort of clinical change.
Carlos?
We follow the same protocol that they described. We, in a frequent base, we do a POCUS, bedside echocardiogram almost every day or with my fellows, we just go with the probe and check quickly that everything's fine, especially if some clinical changes are there, obviously.
Yeah, very much the same, and particularly for weaning, especially when people would think they may recover. So a turn down, so we always make sure the echo's there when we're on rounds to turn it down. You haven't talked about Impella, I guess
Wait,
these
let me real
populations
quickly,
were
though.
not-
I want you to ask her, but I have to.
Wait,
so-
let me tell you what happens in Canada. We don't put a lot of these in because we're not funded, so I can't even make a comment about how many echoes, but when we do it for high-risk PCI, it's a daily echo because we just need that information. But then the pump is in for a very short duration. So unfortunately, I'm so embarrassed because I can't even contribute to this discussion at all.
So, as most things in life, I'm always an outlier. So I've made them quit getting echoes because you say, though, for placement, the answer is whether it's 5, 5.5, 4.9, who cares? And what happened was everyone's moving it every day, half a centimeter. So quit getting an echo unless there's a reason to get it. So we've actually quit getting them, right?
and
Unless there's a reason.
Because we get
I found it was more problem than it was helpful.
Absolutely true. We just make sure it's nowhere nefarious, but otherwise leave it.
Yeah,
Like
leave it
did you see my slides yesterday? It was read as like 7 centimeters in.
Right.
Yeah, it was, but it was
Leave
a
it
giant
alone.
ventricle. It was dead center. Leave it alone. I don't care about that.
Do you follow X-ray to check and compare the position of the Impella?
No.
Following the landmarks? No? But if
Sorry,
you,
David, yeah.
but if you see a significant change in
the
same
angle,
technique, no rotation, significant change in the position, you trigger the echo?
I don't know. I haven't used the X-ray for that.
Okay.
More for the swan position.
So, Joyce, thank you very much.
You're welcome.
We're going to close
Thank you.
this abstract. And I think she did just as good of a job as her medical student.